Hopefully you can all see my slides. So welcome everyone to the fourth in our Radiology Special Interest Showcase webinars. This is session number 4, and we're hoping to focus on emergency radiology and interventional radiology today. My name is Aaron Taylor, and I'm an ST5 interventional radiology resident in the east of Scotland, and I'm the current chair of the Radiology Resident Doctors Forum. So, part of the reason we wanted to put together this webinar series is to try and give you a bit more information in your journey as a radiology trainee. It can be a little bit difficult at times to know what direction it is that you want to take with your future career paths. And sometimes it's not clear what the latest advances in a specialty or subspecialty might be, or what it might be that is going to be challenging in the future of the special interest. So we want to try and address some of those issues. And it can also be that depending on where you are working or where you're training, you might get certain areas of interest that you get limited exposure to, or you may not have the full range of opportunities available. And it's also a chance for some of the special interest groups to come and showcase some of the things that they offer and give a little bit of information about the things that they're doing, educational opportunities, or interesting developments within each area. So this is our main aim with this is to try and inspire the next generation of radiologists, which is all of you listening in today and giving up your free time to listen. So thank you for that. So as I've talked about, the series is a series of focus sessions on the various special interests, and we'll come on to a little bit about the remaining timeline and sessions that are still to come. And the learning outcomes for this are to try and give you some guidance to help make your career decisions, to help hopefully provoke some thought-provoking discussions at the end of the session, and to try and explore the impact on technology, including things such as artificial intelligence that I'm sure you're all hearing a lot about in your local training programs, as to try and get you to have a bit of a think and reflect on the evolving role of radiology within the patient care pathway. And I think potentially with the special interest we've got tonight, I think that's something that will be quite well discussed. Just wanted to say a quick thank you to our team, so both the Radiology Resident Doctors Forum and the Executive Committee, but also to some of the staff members at the Royal College of Radiologists. So Dr. Priya Suresh, who's the Medical Director for Education and Training, has helped make this happen. Anne-Marie Booth-Sarkey and Amy Steeds, who both work within the professional networks, and also Azhar Ali, who is one of the executive committee who's been working really hard to put this together. So I know that everyone has worked extremely hard on this. It's been a lot of organisation and time, and hopefully those of you who attended previous sessions will agree that it's been a very useful and thought-provoking series so far. And we'd also like to move on to thank our esteemed faculty and special interest groups who, without them, it wouldn't have been possible to hold these sessions. And I'm very excited to say that we have 4 excellent speakers tonight who are hopefully going to wow you and inspire you to go into their respective fields. So the format that this takes is it's been 7 virtual sessions in Zoom covering 14 special interests. It runs from roughly 6 to kind of 7:15, 7:30 with some time at the end for question and answers. And the sessions are recorded and made available at the end of the program as well. So the timeline is, so 1 a month. So we've had neuro-rad and musculoskeletal so far, GI and Euro, cardiac and peds, and now we're in the April session 4. And to come in May, June, July, we've got nuke med and breast, head, neck, and thoracic. And then the last session is a little bit more focused on education, training, and research. So that's all I've got to say for now. So I just want to say thank you, and I'm going to hand you over to Lee Warburton, who's going to introduce our first 2 speakers.
So, hello there, good evening. My name is Lee Warburton. I'm an ST3 from Nottingham and a member of the Radiology Resident Doctors Forum Executive Committee, and I'm pleased to introduce our first speakers for emergency radiology today. Dr. New is a consultant radiologist with a specialist interest in radionuclide and cross-sectional imaging. She works at the MTC in Hull and currently serves as the Leicester full-time champion and the conference and educational lead for the British Society of Emergency Radiology. She has held leadership roles as the Vice President and later Co-President of the Society of Radiologists in Training, and has contributed to the FRCR 2A SP examinations for the BSTI panel. She is passionate about teaching and actively engages in educational activities at both local and national levels. Dr. McLevy is a radiologist with specialist interest in emergency imaging, genitourinary imaging and stroke imaging. He works at the Major Trauma Centre in Liverpool, where he's the clinical governance lead and former clinical lead for imaging. He is the current president at the British Society of Emergency Radiology, in addition to being specialist interest group lead for trauma imaging at the RCR and IREFER, as well as the former FRCR 2A exam trauma special interest group lead. He is a regular speaker at various national and international conferences and has published papers on a variety of topics related to acute imaging. So, without further ado, Emergency Radiology with Dr. New and Dr. McLevy.
Thank you, Lee, for that very kind introduction. That makes us sound very important, doesn't it? Myself and Sandra are going to talk to you today about emergency radiology, and we'd first of all like to thank the Resident Doctors Committee for letting us speak at this exciting showcase this evening. So the way we're going to structure the session is we're going to have a little bit of a chat about what is emergency radiology, because it's quite an evolving specialty in the UK. So a lot of you might not be aware that it is its own standalone subspecialty. I'm going to talk a little bit about how I got into being an emergency radiologist and what my day looks like on my day-to-day sessions. And then Sandra's going to run through some interesting cases and hopefully get you all enthusiastic and excited about becoming emergency radiologists in the future. So what is emergency radiology? Well, it's a much more established subspecialty in places like the USA and Canada, whereas in the UK, we're still sort of developing. So it's an area that you can make whatever you like, really. So if we think about what happens in the USA and Canada, is because it's been an established subspecialty for quite a while, the major trauma centres tend to have a little team of emergency radiologists, and they will work a shift pattern similar to what the registrars do. So there are a lot of emergency radiology consultants in the US and Canada who do permanent nights, and they cover pretty much everything that comes in over that time, whether it be CT, MRI, plain film. A lot of them even do cardiac imaging for people who present with acute chest pain. And although they may end up doing permanent nights and long shifts, the shift pattern is actually quite nice. So a friend of mine who works in Toronto does night shifts, but he does 1 week on and then gets 3 weeks off, which sounds like quite a good deal to me. If we move back over to the UK and what the system looks like in our area, a lot of the trauma centres in the UK have a few radiologists who have a sort of subspecialty interest in trauma imaging, but it's usually on the back of another subspecialist area because we're not quite as developed in that world of emergency radiology yet. But because it's not very well developed, it tends to give you a little bit of freedom to do what you want in terms of specific areas of imaging in emergency radiology. It covers a very wide variety of acute imaging. I think a lot of people think of emergency radiology as major trauma. You're going down to that trauma call and having that exciting experience. But actually, it can cover everything that you would see through the A&E and through inpatients. So from acute abdominal work to neuro work, gynae, GU, pediatrics, all can fall within that emergency radiology spectrum. So we kind of overlap with a lot of the other specialist interest groups. And it can be tailored to what your specific interests are within your other subspecialty, and can be whatever you want it to be, really. So how did I end up doing emergency radiology? Because I was relatively new. It was a relatively new subspecialty when I was training. And believe it or not, it wasn't that long ago that I was in your position as a trainee. I'd just passed my 2B exam, my 2A exam, sorry, and my training program director said, you need to decide on a subspecialty to do now. And I genuinely couldn't make my mind up. I liked quite a lot of different things. I liked neuro, but I couldn't see myself doing brains and spines for the rest of my life. I quite liked a little bit of IR, but didn't really fancy the getting up at 2 in the morning to do a thrombectomy or a lower limb angiogram. And what I found is I enjoyed the variety that acute imaging brought. I quite liked doing a little bit of everything, and particularly the acute presentations. And I was lucky enough that my training program director at the time was John Curtis, who was heavily involved in BSER, so the British Society of Emergency Radiology. And he encouraged me to come along to one of their events and see what it was like and discuss it with other sort of passionate individuals from across the UK. And I kind of got a little bit hooked then. I really enjoyed the trauma imaging and the vast variety of different things you can get from emergency radiology. And so I joined BSER as a trainee member. And then I've been with them ever since, really, probably for about 10 years now. And then I've sort of somehow found myself in that role of president. Sort of accidentally fell into it, really. I think I've been the longest serving committee member, and it was just a case of, there you go, the presidency's yours. But we have a very good team behind myself in BSER, particularly those in the educational section, such as Sandra, who have made the experience really enjoyable. So this is what my sort of typical day would look like within trauma imaging. I tend to arrive relatively early on my trauma days. So like we said in the introduction, I do emergency imaging, but I also do GU and a bit of stroke work. So my GU days are a little bit more relaxed. Most of that is outpatient reporting and MDTs, etc. But on my acute day, I arrive relatively early, about 7:30, because we have a trauma MDT, major trauma MDT, at 9 in the morning every day. And this is covered by a variety of different radiologists, all of whom have different subspecialist interests, but like a bit of emergency radiology. So we've got MSK radiologists, GI, and IR in there. And what we do is we discuss the cases that have come in the last 24 hours as trauma calls. And the MDT is attended by general surgeons, orthopedic surgeons, neurosurgeons, and the trauma ward team, which consists of junior doctors, physios, various other therapists. So it's quite a good MDT with a wide variety of clinicians attending. Then the rest of my morning is made up with acute ultrasound. So I run an acute ultrasound list in the morning, and that's interspaced with doing some ED plane films. And the ultrasound list is relatively varied, as you'd expect from an inpatient list, mainly kidneys and abdomens, but a few other bits and bobs as well. And then my afternoon consists of inpatient CT reporting and a bit of MRI. So you can see there's a variety of modalities there, but it's all aimed at acute imaging on my acute day. And these images are just our trauma team. So this is when we appeared on the BBC on the hospital programme a few years ago. And then this is an exciting picture of a helicopter landing in front of our nicely built major trauma unit, that lovely green building at the front there. So it looks very exciting when the helicopter comes in. So what can you do if you decide you want to do emergency radiology? Well, first of all, because in the UK it's not a particularly well-established subspecialty, I'd always recommend having another subspecialty interest, mainly so you can do a little bit of cold reporting as well. As much as I enjoy acute reporting, it is quite nice to do some outpatient sessions, a bit of home reporting, and relax a little bit during those sessions. Doesn't matter particularly what your subspecialty interest is. We've got MSK, neuro, GI, IR, but as long as you've got a passion and an interest in acute imaging. As a junior trainee, I'd encourage you to get to know the A&E team, because these are the people that you're going to be working with the most closely. Show some passion, show some interest in the trauma calls. You know, go down as soon as the bleep goes off. Watch the handover happen between the helimed team or the ambulance team. See what happens in the handover, what happens during the primary survey. Get involved potentially with doing the fast scanning and interpreting some of the plane films that might happen before the CT. And then go down to the CT scanner, issue that provisional trauma report with the A&E team from the trauma console. And it'll show you how you can sort of interact nicely with that clinical team and get yourself known. Attend some educational events. So both BSER and ESER, the European Society, we run educational webinars, etc. throughout the year, and we have regular conferences. So for example, our BSER conference is coming up in November, which is a fantastic opportunity for juniors to get involved and see the wide variety of imaging that happens within BSER. And we'll have a slide later on that tells you exactly when and where that is. And BSER currently are looking for junior members to get involved with our specialist interest group and our society. So if you are interested, go to bser.org, which is our website, or follow us on Instagram and Twitter or X, which is at BSER Radiology, where you can see the opportunities available to you to get involved with the society and see some other educational materials. And then finally, as you get further through your training, if you are particularly interested in doing emergency radiology and an overseas fellowship is a potential for you depending on your lifestyle, then look into it. There are quite good fellowships in Canada particularly, which a few of our trainees have done in the past, and they've got a lot out of that. And because the world of emergency radiology is much better set up in the USA and Canada, you're going to learn some new skills and be able to bring that back to the UK. So that's me done. I'm going to pass over to Sandra now, who's going to take you through some interesting cases.
Thanks, Chris. So I think there's about 10 cases. So if I do run over time, please let me know. So the first case we've got is a CT head, non-contrast, and I'll just give everyone a few minutes before I say anything. If you see any abnormalities, please put it in the chat box and we can discuss them. But this is like a standard on-call case. Patient comes in with headache, typical limited information. So hopefully some people will have noticed some abnormalities. History was pretty vague. Elderly gentleman collapsed, found unconscious, unknown long lie. Just let me double check the chat book. Yeah, perfect. So lots of people have nailed it already. It's a subarachnoid hemorrhage. And we can tell that because there's hyperdensity seen within the basal systems. Yeah, hopefully everyone can appreciate an tentorium cerebelli bilaterally. So that's classical appearances of a subarachnoid hemorrhage, quite a large one, in fact. If in terms of, so now you've established the diagnosis, in terms of causes, any causes anyone's aware of, just sort of for anyone preparing for 2A and 2B, top causes from a subarachnoid hemorrhage. I think one would be, well, given the title of our topic, trauma is definitely one. Yes, exactly. Trauma, aneurysmal ruptures, perianeurysms. I think trauma is the most common, followed closely by ruptured perianeurysms, which is quite high as well. So typically, if there's no history of trauma, this patient, if you're on call, you should definitely get a CT angiogram as well. Depending on the trust that you work at, they tend to lean more heavily towards having a protocol where if you have a subarachnoid bleed, especially one as large as this, you go straight for a CT angiogram just to exclude the possibility of a ruptured perianeurysm or an AV malformation. But in this case, this one was trauma. Perfect. And obviously, urgent neurosurgical consult for those preparing for 2B. Just move on to the next case, please. Oh, yeah, sorry. For the same case, so just to put on the bone windows. Again, hopefully everyone can appreciate those extensive facial bony fractures. The moment you see extensive facial bony fractures, one should always consider Lafort type fractures. And I remember studying for 2A, and it's always a nightmare trying to remember what types of fractures these are. But essentially, there are 3 types, and obviously type 3 being the most severe. As long as the zygomatic arches are affected, is a type 3. As long as the inferior orbital rim is affected, it's a type 2. And type 1 is if there's a fracture along the anterolateral aspect of the nasal bones. In this case, to qualify for a Lafort, more importantly as well, you need to make sure there's a fracture of the pterygoid plates. I think in this case there was, and there was fractures along the, just remember, zygomatic arch. Actually, no, I think the zygomatic arches are intact. It was in the inferior orbital rim, so this was classed as a type 2 Lafort fracture. So that would be in keeping with the subarachnoid hemorrhage. So always review areas, make sure. Yeah, for this case. Perfect. Next case. So this was a patient who was stabbed. This is a great 2B case because, so how I will approach it as a 2B case is, immediately you can tell that the patient's quite unwell, as evidenced by the lines. He's got some surgical clips He's got multiple chest drains on the left and right. There's a chest drain going into the upper end of the mediastinum. There's a nasogastric tube. It's got oxygen tubing as well. So essentially, we've got someone who's very, very unwell. And then following that, we can see there's extensive surgical emphysema over the right neck, left clavicle, and both chest walls. And most importantly, as long as you see surgical emphysema, especially when it's extensive as like this, the first thing you need to exclude the pneumothorax, which I think is quite hard to appreciate. But there is a pneumothorax in the right apex. You can just, yeah, exactly, perfect. Yeah, you can see a pleural lining quite distinctly there. And next important question is make sure the mediastinum is well oriented and there's no evidence of deviation, which then would be suggestive of tension. And after that, you can go back into the lungs. It's a bit difficult given the overlying subcutaneous gas, but essentially there is no evidence of collapse. There's some shadowing over the left hemithorax in the upper and mid-lung zones, which could represent contusions. Given that this is most likely a trauma, because obviously the right mid-clavicle is completely into, the scapula, is fractured. The clavicle is intact, the scapula is fractured, and it's a bit hard to appreciate, but there are rib fractures bilaterally. I think in the next image, Chris, we took a picture lower down. Yeah, and we can see this for the subcutaneous gas extending down to the abdomen. And I think the abdomen, there was no evidence of any pneumoperitoneum, which was reassuring. And obviously making sure that the lines are all appropriately placed and nasogastric tube is placed. But this was someone with a stabbing injury that basically gas was going all the way into his pleura, causing the pneumothorax as well as the subcutaneous tissues. So quite an unfortunate chap. Next case was a history of facial swelling and flushing. Shadows suggest left lower lip collapse. Yeah, I think that's always a good shout. Especially when you lose for left lower lip collapse, especially if you lose the hemidiaphragm, that's very suggestive of a left lower lip collapse. So this is the arterial phase going from the base of skull all the way down. So with a history of facial swelling and flushing, hopefully you can think of a few differentials already before we look at the scan. This was a scan that I saw on nights when I was a reg. It was quite unfortunate. It was an elderly lady with just sort of presenting with breathlessness. Given her facial swelling, they were worried about a SVC obstruction. They had no other history for her. SVC syndrome. So yeah, perfect. So you can see immediately that there is a soft tissue mass lesion in the mediastinum, which is causing a degree of narrowing of the SVC. I think it almost looks like a slit at one point. Yeah, see. So that's the SVC next to the aorta. It's very slit-like, which is very scary, obviously, because it means it could go off at any moment. Also, there is narrowing of the right pulmonary artery, severe narrowing of the right pulmonary artery, and as well as severe stenosis of the bronchi, and I think the lower trachea as well. So unfortunately, this was a patient with a history of cancer, unknown diagnosed cancer, which we never got a histology sample, but because unfortunately she passed away quite soon after the scan was done. But yeah, this was a nice case of an SVC obstruction, which you don't come across very often. Was there liver mets? Oh, that's a good spot. Can't remember if there was liver mets, but yeah, let's have a quick look. Was there liver mets? Oh, so that low attenuated lesion, that's quite well defined, so that's classical of a simple cyst. But it's always a good shout, obviously, to look for liver metastases in anyone in malignancy. Yep. Perfect. If you move on to the next case, yep. So this one is someone with abdominal pain. Again, very limited history from A&E. So you got severe stenosis of the aorta. Moving down. So hopefully everyone can appreciate the abnormality. This is quite a common case that you'll see on call and in your 2B vivas. And hopefully if you do see it in your vivas, you should knock it out of the park. But essentially we've got a massive dilated abdominal aorta with retroperitoneal thickening and hyperdensity. I'm probably embarrassing myself in front of the IR guys, but from a 2B perspective, this is a classical appearance of a ruptured, not thoracic, abdominal aorta. I think it might be a bit confusing given the orientation, but this is below the diaphragm, and it's an infrarenal abdominal aorta. Just eyeballing it, it looks to be at least 10 centimeters. But most concerning of note is that there is hyperdensity fluid just anterior to it, which is active hemorrhage. So this patient's got a ruptured AAA essentially. And depending on the institution that you're in, you classically have a triple phase. I've only added the portovenous phase just to highlight the size and appearances. But essentially, when you see this, you gotta pick up the phone and call your vascular surgeons as well as the IR team immediately. Lovely, move on. So this is another history of back pain. If it plays. So I've only included the bow windows because within a few seconds you're gonna quickly see the abnormality. So these are actual cases from Hull. So hopefully you notice there's a bit of a pattern. There's a fair bit of stabbing that we get across Hull, which always keeps your nights interesting as a reg. This is one that I saw on nights, and very impressively, there is a 9-inch kitchen blade that's been shoved into the patient's spine. And very fortunately, as you can see, he's missed all the major nerves, spinal cord even. The patient had no symptoms whatsoever, even though I consistently, in fact, I even went across to A&E just to clarify if he had symptoms because I was very happy to do an MRI scan, but there were no symptoms. We did end up doing an MRI scan and his spine was completely intact and fine. So a very, very lucky break. This very young patient. But yeah, always be worried about spinal injuries, spinal transactions, hematomas, epidural hematomas. Next case is a patient with low GCS. So this again is sadly quite a common type of scan that we see in Hull. It's not slightly trickier, so I'm just gonna be quiet and hopefully let someone else mention in the chat group if you see any abnormalities. Once you see it, you can't really unsee it. So a bit of history, low GCS, young patient, no history of trauma. Yeah. History of IVD use. Ah, perfect. Dr. Tanya is perfect. Yeah. So hopefully you can notice there's complete loss of the white and gray matter differentiation. You can't even see it really. And there's a bit of sulcal effacement as well, suggesting edema. So this is someone essentially with a hypoxic brain injury. Sometimes you can get the hyperdense subarachnoid hemorrhage, hyperdense subarachnoid sign, which is not in this case. But the main thing is you can't differentiate between the white and gray matter. And then when you did a bit more digging, it was actually a patient who tried to commit suicide by hanging, and as a result was found quite late. Therefore, that's how he managed to get the hypoxic brain injury, which is quite unfortunate. But yeah, it's quite a tricky case if you've never seen one before. Yep. So moving on, I think this might be the last case. Again, this is quite an interesting case on call, an arterial phase scan, and hopefully, I'm sure my IR colleagues will provide a bit more insight in terms of management. But this was someone who just came in with acute abdominal pain. Vascular reg said they couldn't really feel his pulses in his femoral pulses. Query, peripheral arterial disease. And I don't like to look at lower limb angiograms, but in this case, it was quite an interesting scan. Yes, perfect. That was an aortic aorto-iliac occlusion, which is otherwise called Lyric syndrome. So classically, you present with complete occlusion of the abdominal aorta distal to the renal arteries. You get a classical presentation of erectile dysfunction, thigh claudication, as well as absent femoral pulses. And in addition, you get the typical 6 peas, pallor, pulselessness, paresthesia. I can't remember the other three, but yeah, you get the drift. But this was someone with Lorate syndrome, acute acute ioto-iliac occlusion. Sorry, bit of a mouthful. Acute on top of chronic. Potential. I think the signs for chronic is there were signs of collateralization, which, in fairness, now that I look at it again, yeah, there are signs of the signs of collateralization, which, yeah, could suggest a degree of chronicity. But essentially, in terms of treatment, I think this patient went on to have an endarterectomy or a bypass. I think it was a bypass, but classically you can approach both, depending on how well and how fit they are. But yeah, so that's a summary of, I think, 10 cases that just highlights the different types of trauma or emergency findings that you can see on call, which I think, going back to what Chris said, that's what makes it interesting. I think that's why, I think if you chose a specialty, regardless of what other specialties you choose to specialize in, like chest or GI or cardiac, I think it's always important to have some acute sessions just to keep things interesting. And depending on where you are in a DG, I think, so for us in a major trauma tertiary care center, we do split the neuro and the body on calls. So for example, I only report body CTs. I don't report anything above the neck. That goes on to my neuro colleagues. But I think it just depends. When you become a consultant, it's quite flexible what areas you choose to specialize in. And it's quite nice because, you can always, I have neuro colleagues who report acute CT body scans sessions just because they want to. So I think in that aspect, it's quite flexible. Chris has already plugged our conference that's happening in middle of November. It's happening in Hull, and registration is still available. We do offer discounted rates for junior resident doctors and allied healthcare professionals, as well as medical students if there are any. But it's going to be a really good meeting, and we're due to release our program quite soon. So if you stay on our website, we'll keep you updated. But yeah, going back to Chris, if there's anything to add.
No, they were really interesting cases. Thank you, Sandra.
Yeah, particularly like the knife one. That really, I was half asleep, but that really woke me up when I was on call.
Yeah, I presume they pulled it out before he went in the MRI scanner.
Yeah, we did. Yeah, thankfully I had the foresight to do that. I didn't pull it out, but hopefully someone else did.
So welcome everyone to part 2 of tonight's webinar on interventional radiology. So I'm Fran Chi and I'm an ST5 trainee at Imperial. I'm currently trainee rep on the RCR IR committee and a clinical research fellow funded by the RCR and the VSAR. I'm here to introduce speakers for the next section. So we've got 2 amazing speakers tonight who are going to provide a broad insight into IR, covering some of the subspecialties within IR, some of the procedures we do, routes into IR, and what life is like as an IR trainee and consultant. So first, I'd like to introduce Dr. Alex Barnacle. So Alex is a consultant paediatric interventional radiologist at Great Ormond Street Hospital for Children. She currently sits on the RCR IR committee and the executive committees of BSIR and CERSI. She is the clinical lead of the first ever IR girth review and a real champion of women in IR and an incredible role model in our specialty. And presenting together with Alex is Dr. Kat Harborne. So Kat was appointed as an IR consultant in Worcester in 2024, and she also maintains a diagnostic interest in thoracic imaging. She was a previous chair of the BSIR trainee committee, through which she's done some absolutely amazing work. And she's got an incredible story as a working mum in IR. And when I first heard it, I think she's an absolute superwoman. So welcome to Alex and Kat, and over to both of you.
Fran, thank you so much, and thank you to all the organising committee. It's an absolute pleasure to be here and present today, and to be presenting with Kat as well. Kat, thank you for joining me for this. I think it's really helpful. We're at sort of either ends of the consultant career spectrum, and it's really helpful for I think trainees to hear both of our perspectives. So without further ado, here are my slides. So what we wanted to talk about today was interventional radiology, what IR is, what a career in IR might look like, what training in IR looks like as well, and the different options there are for you, We wanted to tackle briefly some of the preconceptions and the challenges that people might anticipate around a career in IR and speak to those. And then finally, to point you towards some resources to tell you a little bit more about where you can find out more about IR and get to meet some of us and see a little bit of what we do. So what is IR? This is probably the kind of image that most people think of when they think about stepping into the interventional radiology suite. And it's certainly, when I started as a radiology trainee, it was quite intimidating to me and not an environment that I thought was one that I would ever feel comfortable in. I used to get tachycardic every time I put scrubs on, but actually it drew me in over the years. But it isn't just sitting in the angiography suite like this, it's being part of a much wider team within the radiology department, but specifically within IR with the nurses and the radiographers. And I think there's something particularly special about interventional radiology, that you have a very close-knit team around you. This is the team from St George's Hospital in South London. There are lots of, as I say, ideas that people might have about what a career in interventional radiology might look like. And many people think that it is predominantly vascular IR, such as you can see on these images here, that we're predominantly moving through the blood vessels and treating blood vessels, and that this is what IR is all about. But one of the messages that Kat and I were keen to get across today is that there's a lot more to IR than just that. So this is, for instance, this is a percutaneous transhepatic angiogram, or a PTC, where we have punctured the right lobe of the liver here, got into the biliary system, which is not often an easy thing to do. The system is mildly dilated, and got into the biliary tract and injected some contrast, and you can see that there are strictures and pathologies lower down in the biliary tree here. So this is non-vascular IR at its best. This is a nephrostomy tube sitting within a minimally dilated collecting system of the right kidney. And of course, there are other things, biopsies, drainages and aspirations that people tend to think may sit within the diagnostic radiology remit, but often those are really complicated procedures, such as this transrectal drain here, and this transvaginal aspiration of a collection here. So even what may seem relatively straightforward drainages and aspirations can be very complex and require significant IR skills. There's, of course, the whole range of MSK interventions as well. And this is a vertebroplasty case here, which and these are certainly high risk and skilled procedures that MSK radiologists may well be interested in as part of their interventional remit. Here's an example of a non-vascular IR procedure. This is a PCNL, or a percutaneous nephrolithotomy procedure, removing kidney stones in a young child here. So you can see the ultrasound on the left shows a very dilated kidney. You can see a dilated left upper pole calyx here. If you can see my arrow, this is the spleen. And here you can see multiple echogenic foci within the interpolar and lower pole region of the kidney. And the plain film here shows what we're talking about in terms of the stone, which partially shows up on the X-ray here. This is what historically a surgeon would do to try and remove those stones. And you can see this is really invasive surgery. They've had to cut through the capsule of this kidney here to get to these stones. They may be able to get to the stones in the renal pelvis, but they're certainly not going to be able to get to stones in the individual calyces. And this type of approach often leaves many, many stones behind. And I've just chosen this as one of my favourite procedures, really, but I think it very elegantly shows what the surgical and the IR options for this kind of disease would be. This is an ultrasound-guided puncture of the kidney here in this young school-age child, using a kellet needle there. Once we're into the system, we have just got a plastic sheath in the kidney, and you can see urine dripping from the tip of that sheath there, and a guide wire in through the sheath. And on X-ray, we can see we've got access into a couple of different calyces here. This is a different case You can see there are a huge number of very small stones in this kidney here, with these 2 guide wires, one going down the ureter and one curled in the upper pole. Over those guide wires, we've put a series of metal dilators which have dilated that track up and up until it is big enough here, as you can see, to be able to accommodate the urologist's camera. And then the urologist will come along, and into that system they will insert either a grasper or a camera or whatever they need to get in there. And here are some examples of that. And this is what they look at as they go down with the camera through the sheath. And what you're really hoping as the IR is that you see a stone at the end of the corridor there, and that allows them to get the stones out really easily. And this was the outcome at the end of the day, which is certainly a very palpable and real evidence of a day's work well done. What are the things that I love about interventional radiology? I love that it's very hands-on. This is Cola. She was a very junior doctor when she came to us for a couple of taster weeks to see what interventional radiology was all about, and we were able to get her scrubbed and doing procedures in the IR suite with us. And certainly people who go into radiology after a few years, there are some who definitely miss the hands-on nature of what we do, and that is one of the things that really attracts them to interventional radiology. Secondly, it's hugely innovative. This is an image showing you the different catheter types that we might have hanging on the wall in an IR suite, and this just demonstrates the huge number of different catheters and wires that have been developed over the years by innumerable different people all over the globe to get us into all sorts of different areas and different vessels within the body. These are just some examples of different IVC filters. And again, this just shows innovation in IR at its best, trying to solve a relatively simple, you would have thought, problem of trying to stop clot getting up to the heart and the lungs from the lower limbs. But these are just some of the tools on the shelf of our armamentarium, just displaying the innovation that it needs to problem solve in IR. It's really technological, and this is something that appeals to many other people for IR, is all of the technology at our fingertips. This is intravascular ultrasound. You can see these are some images here. Ultrasound mounted on the catheter that you put up through the artery or the vein. And it has given us exquisite images here, bottom right, of the different layers of the blood vessel wall and the atherosclerotic plaque on the left, which has got a rupture within it. There's a little bit of artifact on the left-hand side of the image from the guide wire. And after treating that plaque and doing an angioplasty here, we are able to use IVUS to look at the results that we've achieved and see whether what we've done is adequate. It's also really varied. So between Kat and I, we would probably treat patients at both ends of the life spectrum here. Kat would feel a little bit more comfortable, I suspect, treating one of these patients, the patient on the right, than I would. And equally, I would feel deeply uncomfortable treating the patient on the right, but a little bit more at home treating the preterm neonate on the left. Many of our patients are unwell inpatients who are referred for a huge number of diagnostic procedures in terms of angiogram, venography, biopsy, etc., but also for interventions. But not all of our patients in IR look like this. Increasingly, a lot of elective IR procedures are aimed at very healthy patients who may have issues such as prostate hypertrophy or uterine fibroids. And so often you may develop a practice that has very well patients in your clinic who are looking for alternatives to conventional surgical treatments, perhaps. It's also very varied in the types of work that you do, in that some of it might be very elective like that, but it may also be very acute if you work in a major trauma centre, as we've just been hearing from our speakers earlier before the break, or if you work in a centre that has a high volume of vascular IR, a lot of that is going to be emergency work. But it's also very varied in the types of work that you do. So we've already covered from the far left that you might be doing vascular IR. You may develop an interest in non-vascular IR. In the central image here, this is a ureteric stent. And your practice often may cover both of those, and there's no need to decide that you necessarily want to do one and not the other. And then an increasingly fascinating, very large branch of interventional radiology, is an example of which on the right, we've got cryoablation or thermal ablation of a renal cell carcinoma on the right-hand side there. So this is part of the interventional oncology armamentarium, which is increasingly seen as the fourth pillar of cancer care after chemotherapy, radiotherapy, and surgery. And interventional oncology is certainly a huge focus for many interventional radiologists and a growing field. It's also very personal. Again, this is the team from St George's, and just an example of how you get to meet your patients, explain the procedures that you want to do, and see them again afterwards in clinic or on the wards as they hopefully are getting better. Having those one-to-one conversations is something that many diagnostic radiologists without an IR component in their job plan miss. And finally, it really makes a difference. So you might think that vascular access, such as this dialysis catheter here, are pretty straightforward, relatively uninteresting aspects of our job. But in my practice, for instance, that allows a child like this to be able to get his dialysis regularly and safely and stay well. And a very simple procedures such as the gastrostomy insertion or exchange in a small child like this allows this child to be able to get to nursery and have some independence in his life, and for the family to be able to feed him very easily, him to be without an NG tube and thriving. So what might a career in IR look like? You might decide that vascular interventional radiology and being in the IR suite often with the vascular surgery team, such as you see here, is right up your street and what floats your boat. This is a complex thoracic vascular stent, aortic stent, on the left here, known as a TVAR, and actually this is a chimney. You can see that there are a couple of stent extensions going into the main vessels branching off the thoracic aorta to treat a dissection that has encompassed the origins of those vessels as well. So a life in the IR suite doing in vascular IR may very much be what it is that you want to do. But you can also mix your job plan, and there are as many job plans, I think, options for interventional radiology as there are doctors doing interventional radiology, to be honest. You might find that you still really want to have a diagnostic and a reporting component in your job plan. You might still want to be doing hands-on diagnostic radiology, whether that's in the fluoro suite or in ultrasound. And you certainly may find you still want to be in on the MDTs, leading many of them and helping with the decision making and the diagnostic work. And all of that is compatible with having some sessions of IR mixed into your job plan. It is ultimately, at the end of the day, of course, really important to remember that we are all diagnostic radiologists at heart. These are a couple of cases from my practice. On the left, a baby, a 2-day-old baby with a benign but extreme vascular tumour of the liver, and it was crucial to understand the pathology here before we even thought about intervening, given that embolization of this tumour to save this child's life was highly risky. So you need to understand the pathology before you even can decide whether intervene. And on the right-hand side, this is mid-aortic syndrome in a young child as well. It's a very rare pathology that in a child is going to be very different to aortic pathology, abdominal aortic pathology in an adult. So it is important that you understand what's going on in order to develop as an interventional radiology with expertise. Kat's going to take over now and talk a little bit about what training in IR looks like. Thanks, Kat.
So I gather we've mostly got resident doctors from radiology training schemes on the call here. So the first couple of boxes are not really going to be relevant for you guys. So interventional radiology is traditionally a 6-year run-through training program, and previously we would have chosen to subspecialise in interventional radiology, or formally made our decision in ST3. And then at ST4, you would start your IR training and go on to the 6-year run-through scheme. As of the past couple of years, there has actually been an option to preference interventional radiology when applying for radiology as a subspecialty. And so some of our trainees who are ST1s to 3s are already badged as IR trainees. and will be IR trainees throughout their training. That being said, there will always be people who, for whatever reason, decide actually having had a bit more exposure to IR, it's not for them. So there is always the flexibility to opt out of the IR training and switch to traditional diagnostic radiology. And similarly, if you don't have an IR badge number as a core trainee, it doesn't mean that you can't train in interventional radiology. So typically people will do core radiology training followed by IR training ST4 to 6, and usually in at least the ST6 year, and sometimes for some or all of the ST5 year, that will be on the IR on-call rota as well. As Alex was saying, there's a huge variety in the things that we do, and it's really important as a trainee to get exposure to some of the stuff that only really happens at 3 o'clock in the morning, and to get used to getting up in the night and making those decisions. Following ST6, you may wish to do a subspecialty fellowship, which could be in the UK or abroad. It's not essential. Personally, I didn't do one, but it's something that many of my peers and colleagues have really benefited from. Yeah, if we can go to the next one, please. Thank you. Lovely. So when we train in interventional radiology, it's known as a dual CCT. So that means that you have a CCT in a CCT being a certificate of completion of training for clinical radiology as well as interventional radiology. And it's really, really important to have that really good grounding of diagnostic radiology. So we still have to do all of the same curriculum sign-off that our diagnostic radiology colleagues have had to do, as well as the IR curriculum sign-off as well. And then the next slide, please. Now, there is no RCR exit exam for interventional radiology. So we all sit 2B, we get our FRCR, and that plus all of the work-based place assessments and curriculum sign-off is all you need to get your CCT in interventional radiology. There is an exam called the EBIR, European Board of Interventional Radiology, which is an exam that comes under the umbrella of CERSI, which is the European IR Society. And this is kind of an additional exam, but it has been the trend over the last few years for people to sit this either in ST6 during a fellowship year or even in the early consultant years. The exam's been around for about the last 10 years. I sat it towards the end of my training, and personally I found it really, really helpful. It's an IR specific exam which covers the breadth of IR and teaches you a bit more about the kind of why we do what we do. And yeah, if you can move on, please. So this is just a sort of an example of my kind of working week as an LTFT ST6 trainee in a district general hospital. So at this stage of my training, I had about 3 months left to go, and I was kind of acting as a consultant in some respects. So this is very reminiscent of what my job plan looks like now. So I work in a DGH where we have a sort of second site which is more of an elective site, and then we've got a more acute site. So I would do a day on the elective site doing things like drains, CT or ultrasound biopsies, nephrostomies, nephrostomy exchanges and PICC lines, and it's kind of mostly elective work. So those patients are all quite well looked after on a day case unit, and it's usually a very varied day. I subspecialized in chest or thoracic radiology as well as intervention. So I sometimes take part in the lung MDT, which involves prep and sometimes reporting things if they're not reported in time for MDT, and then doing a lung MDT in the afternoon. But I would also at times do an ultrasound intervention list or IR clinic. And I think IR clinic's really, really important, and it's a really good training opportunity. As a trainee, when you're learning IR, you really want to get hands-on and learn all of the skills and be proficient and understand all of the different kit and things that we can use. But actually, it's also really important to understand kind of what happens before we've decided to do a procedure, the decision-making process, the consent process, and actually talking patients through, what are the risks and benefits of this procedure. And it's something that is vital when you work as a consultant. And so that's also really important training to be sort of undertaking as a resident in IR. So this is just an example of what my working week looks like as a 60%, so 3 days a week trainee. Yeah, we can move on now, thank you. And this just shows some sort of varied examples of my training. So these are all taken in the same place. So on the left, you can see that's the lung MDT, which I was a core part of and still am now as a consultant. I completely agree with what Alex was saying about how we're really, we work with such a lovely team within interventional radiology, and some of my best friends at work are my nurses and radiographers that I work with. Yeah, if we move on, please, thank you. And I think that's everything from me.
Kat, that's brilliant. Thank you so much. So Kat and I were discussing some of the things we wanted to cover in terms of some of the preconceptions and the challenges that people think that IR might bring. We don't necessarily have all of the answers, but we wanted to be honest about them. There is, I think, often a preconception that you have to be doing vascular IR in order to become an IR, and that's not always true. A lot of the fellowships might focus on vascular IR if it's within a vascular centre, but there are many, sorry, not fellowships, but just training schemes that SD 4 to 6 training may have a vascular focus, but there will be other centres that have less of one, and you need to be able to see it all and know what it is that you enjoy and what you don't, and what's going to motivate you. So you will get exposed to all of it, and should explore what the options would be on different training schemes to make sure it's something that might fit best for you. You might find that you want to do as Kat has an interest in chest radiology, you might have an interest in uroradiology, and you can see as a uroradiologist you can expand your remit within that role, for instance, to be doing prostomies, neph exchanges, ureteric stents, or even PCNLs as part of a job plan or a job as a uroradiologist. Some hospitals even with a non-vascular IR on-call rota. And you might find that you want to still incorporate, as we talked about earlier, having reporting and MDT, leading MDTs in your job plan, and all of that is indeed still possible. The second bit, I put this in just to acknowledge the fact, which actually we've already talked about a little bit, about on-call being very onerous for IR. Again, that isn't always the case. It depends where you end up working, but that is where the best cases happen and where you often get the most job satisfaction, I think, in your role. I can see Kat nodding there and Fran as well. And, you know, I think we all know from some of the urgent work that we do as diagnostic radiologists too, that's where the satisfaction often comes from. And then there are some preconceptions that there are not many women in IR. Well, inadvertently, I think we've smashed that today with having Kat and I and also Fran on this webinar here. This is the team from St George's. They've got a large number of female IRs there, and this was the day when it was only female IRs in the operating suite, which was great to see. But there are lots of initiatives around promoting and supporting women in IR so that they can thrive in what they do. And certainly that, I think that is not the way that the specialty looks now, and certainly not the way that it's heading. And there is great camaraderie and support to be found for women who want to go into this subspecialty. Just to finish, we wanted to cover some resources that would be available for you. IR Juniors are a really excellent group, come in under the umbrella of British Society of Interventional Radiology. There is some information about them there. You can find this if you Google them and look on the BSIR website. They put a huge amount of events and social media posts together that can help you to navigate your way towards IR. Then there's BCERT, or the British Society of IR trainee section, who are for interventional radiology trainees, and they also have a lot of great content available. There's Unite, which is a research collaborative, as you can see here, to look for to promote research and interventional radiology that has been going for 3 years now and delivering some really excellent projects. It's worth looking at that. If you want to get involved in some IR projects to boost your CV and your experience, there are some great podcasts out there. The American Society of Interventional Radiology has a Kinked Wire podcast, which has lots of great stories and interviews with interventional radiologists. And Backtable is a radiology podcast, but you can see here when I put this together last week, I looked at how many interventional radiology podcasts were out there, and there are 510. So there's plenty of content within Backtable specifically on IR. Finally, of course, at the centre for British trainees is the British Society of Interventional Radiology, which is where most interventional radiologists find their tribe. There is an annual meeting this year in November, but there are also special interest groups within the BSIR. So there's a vascular group. They've just had their first national meeting, Vitals, which was highly successful, the interventional oncology group and the pediatric group. And all three of these have a meeting every year that's a much smaller niche meeting that's really friendly and approachable. Can get to meet people in each of these specialties. The pediatric IR one is on the 19th of May, so that one's coming up really soon. And that one is in Birmingham. I'm going to leave it there. We are up on time, but there may well be some questions for us and for the emergency radiology team. So I will hand back over to our hosts. Thank you.
All right, thank you both. Those were fascinating talks and some great images as well of cases. And I think there was quite a few things you said there that really chimed as an IR resident that's still kind of training. And particularly, as you say, sometimes these simple cases are sometimes the most rewarding and the things that can get patients home and improve quality of life. As you say, and the things that actually as an ST4, ST5 you can be doing pretty shortly after you start training with not too much difficulty. So yeah, that's great. I was going to ask a couple of questions just whilst we wait for things to come through in the chat. So in fact, actually, we've got a question here, so I'll start with this one. Someone is asking if someone's definitely interested in MSK diagnostics but has an interest in IR, but they're not completely sure. How difficult is it to move kind of between pathways? Can an IR consultant become a diagnostic MSK consultant if she decides to move at a later stage and decides they maybe don't like intervention and want to go on to a diagnostic specialty?
Kat, did you want to speak to that? I can too, but you might have thoughts.
Yeah, so I think that's an interesting one. I think it depends on what you mean by an IR consultant and what kind of IR consultant you would want to be. So MSK as a subspecialty actually has an awful lot of procedures. So if you're someone who wants to do procedures, but you don't necessarily want to be on the IR on call rota, then actually pursuing MSK, and it's then about thinking about where you want to work. Because if you were an MSK radiologist in a tertiary referral centre, your job plan and your day-to-day life would probably be very different to an MSK radiologist in a DGH who does a bit of MSK with a bit of other sort of cold reporting and duty on calls, that kind of thing. So I think it's very centre dependent. Now I trained in chest as well as IR. I work in a DGH and I'm very much a DGH level thoracic radiologist. I could not do a job in a tertiary referral centre as a thoracic radiologist. But I'm great for the sort of DGH level of radiology. And I think that it's very difficult to try and be tertiary referral centre level in more than one subspecialty. So it then becomes, you almost got to be strategic and think, and it's so hard when you're earlier on in training because those 5-6 years, they fly, they absolutely fly. And you really have to think about, where do I see myself working? What sort of place? Do I want to be a big fish in a small pond or a small fish in a big pond? Where is my tribe where I'm comfortable working? So it's very difficult to kind of give generic advice, but hopefully that sort of answers the question a bit. And I don't know if you want to chip in at all, Alex.
Yeah, Kat, thank you. You're so good at just putting the very reasoned view across, I think, on the different ways that you could do it. Certainly, there are people who go into interventional radiology training, and as Kat said earlier, it turns out not to be for them, or they want to move because the scheme that they're on focuses perhaps on vascular, or doesn't focus on vascular enough. So even within IR training schemes, you can move, but you can do a couple of years of IR training and then decide that it's not for you, and talk to your TPD and your centre about move. No one's going to be locked into something forever and put through something they don't want to do. I'm not sure if that is helpful for the person who asked. Can an IR consultant move to diagnostic completely? Yes, because you are fully trained in diagnostic radiology, so you will still get your CCT. As Kat said, you are dual accredited, so you are a diagnostic radiologist, so you have your CCT and you can take up a post as a diagnostic radiologist.
Thank you very much. And I've got a question just for Chris to kind of move on to some emergency radiology topics. But you talked a lot about the trauma MDT, and that's something that we don't yet have. And despite being a trauma centre, is that something that was difficult to set up? And is it something that you get kind of residents involved with in any way, or is that something you think residents could have a bit of a role in helping with?
Yeah, definitely. It was quite easy to set up, to be honest, because the surgeons were already kind of meeting and having a little board round at the beginning of the day. And I think it kind of happened accidentally in that the radiologist went up to it and showed a few images. And they thought, wow, this is fantastic. We can actually see what they're talking about in the reports, and we can point at the pathologies, and we can get almost a third read of the scan in the reported by the registrar overnight, looked at by the on-call consultant, and then you're getting a trauma radiologist looking at it. So they really enjoyed that. And we actively encourage our trainees to come to the MDT and present, because they're all sort of hot review cases. It's all acute pathology that you're seeing on a day-to-day basis as part of your on-call. So it's the kind of things that you're used to. And the general surgeons and the orthopods, they're actually quite a nice bunch that work on our trauma rota. So they might seem a bit terrifying when they're looking over your shoulder while you're trying to report your trauma scan. Sort of hot there, but in the MDT, they're quite nice, and they very much appreciate the support they get from the radiology team here.
That's great, thank you. And for Alex and Kat, just wondering, what do you see as the kind of next big areas of innovation and development in IR? Do you think we're a group that are going to be using AI tools quite soon, or do you think there's another area that's really going to explode over the next few years?
I think AI definitely has a role within interventional radiology, but it is really early. Oh, we have someone joined us on our webinar. That's great. Someone a little bit smaller. So we interventional AI definitely will have a role, already has a role in interventional radiology, in terms of perhaps more how we plan our procedures rather than how we actually execute them at this stage. But it is certainly a huge growing area. And CERSI, which is the European IR Society, has got a specific work stream looking at the implementation and development of AI within IR, and it might be worth going to the CERSI website to look at some of the resources they have on there in terms of interventional radiology, in terms of AI in IR. I think the other big area is interventional oncology that continues to grow, especially as we now have enough, we've been doing it for long enough that the outcomes, we've shown that that the responses to many of the procedures that we do are durable. So we can now compare 10 and 15-year outcomes of IO compared to surgery, whereas that data has been lacking before. So that is increasingly strengthening the case for a lot of areas of interventional oncology. And finally, I clearly have a conscious bias, but there is an increasing interest in paediatric IR, and I think that is an area that needs to grow in the UK, but where there is increasing interest, and there will be more centres that are realising that they need to have people with an interest in paediatric IR in their centres to make sure that all of the patients in their catchment area get the IR options that they should be offered.
Yeah. And Fran and Lee, if you've got any questions, well, please free to chip in. But leading on from that, I was going to ask you, so the In terms of pediatric work, is this something that you think we should be getting more people going in as dedicated pediatric IRs, or should we be trying to upskill just general IRs across the country to feel more confident to do procedures, use the same skills, but just on people that are a bit smaller?
Yeah, absolutely. That's such a pertinent question. I think pediatric IR is a really good example of the different pathways that you can come to it from, because we have as many, in fact, probably more diagnostic radiologists, so pediatric radiologists who want to do some of the IR procedures along with it and want more confidence in doing biopsies and drains than usually adult IRs who never envisaged treating children when they first went into interventional radiology and can find it all quite overwhelming or intimidating. And so in our department of 6, we're an unusually large department, we've got people who have come at it from both a surgical or pediatric radiology background and from an adult IR perspective. And I think it's really good to have a mix of both because we all bring different skills to the table. To your point about cross-skilling, absolutely. There aren't enough people ever to be interested in doing pediatric IR full-time, and there's not a need for that either. I think it's far more common for there to be departments that need somebody with an interest in it and some experience in it who can treat the older school age children who need something done without having to ship them many, many miles to the other side of the country, potentially unstable at the time, and could get their treatment closer to home. But equally, there is a place for those who have trained in a bit more depth and are working in a specialist centre who can take the more complex work or children at the extreme young ages, for instance. So there's a place for both, definitely. And we're working with the college currently. In fact, I had a meeting about it only today, about developing cross-skilling courses for adult IRs, as well as paediatric surgeons and anaesthetists, to give everybody a chance to learn these skills and share them. Yeah. There was one other point, actually, Aaron, that I wanted to make, not related to your last question, but that Kat and I had been discussing. And we do hear occasionally that people in their early years as a radiology trainee express an interest in IR and can be put off by the consultants in their department who will say, "Are you sure you want to do that? You can't do it from home. You are going to be up at night. It's difficult if you're a woman. You can't do it less than full time." And we would really strongly advocate that if you are hearing that message in your own training scheme, reach out to other people to hear a different point of view, because that isn't the only message. And I think we've made that point loud and clear today. But there is a female IR ambassadors scheme about to be launched by the college next month, where you'll be able to ask to speak to one of the female IRs there if you are a trainee who wants, and not necessarily even a female trainee, but a trainee who's interested in working less than full time, and exploring what part-time options might be available and what some of the challenges are in doing IR. And there are plenty of other people that the BSIR, BCert or IR juniors can put you in touch with to hear different messages. So please keep asking. Don't necessarily be put off by the first person who gives you a less than positive response to your questions.
Yeah, that's great. Thank you very much. And yeah, as previously mentioned, great to have 3 women in the panel tonight representing IR. So 3 very good role models. So thank you for that. And finally, one more question about emergency radiology, and I think we might have to wrap up after that. So Chris, someone was asking a little bit more about the kind of parent specialty and kind of secondary specialty interest. So someone is asking, is it theoretically feasible from a CCT perspective to subspecialize in ER during ST4 and ST5 if one wanted to do so, or have ER as a parent theme and then your subspec is almost a secondary kind of interest with ER as the main focus?
That's a tricky one for me to answer. I'll probably need clarification from the college. So it'd be worth speaking to your TPD and ask them to maybe have a chat with the RCR. But emergency radiology is a recognised specialist interest group by the college, and your CCT, as far as I'm aware, is in diagnostic radiology. It doesn't have a specific subspecialty. So really, once you've got that, you can call yourself whatever you like. And you can retrain post CCT and do things that you haven't done as a trainee. What I would say is most hospitals will want you to have another subspecialty so you're more useful to them. They'll want you to cover some kind of cancer MDT because that's where a lot of your job plan funding will come from. So personally, I wanted to do emergency radiology, and the hospital I wanted to work at was short of a GU radiologist. So I thought, oh, fantastic. I quite like a bit of urology, so that works for me. So it's probably worth chatting with your TPD and then having a chat with the hospital that you actually want to work in and see what works for them.
Okay, that's excellent. Thank you very much. And I think we'll probably need to wrap up there, but just wanted to say thank you again for all giving your time. Sandra passed on her apologies. She had to go. I think she's away on holiday at the moment, so wasn't able to stay for the Q&A, but I'm going to put her email in the chat as well in case anyone had any specific questions they wanted to ask her. But yeah, thanks everyone for giving up your time to give these really interesting talks. Thank you also to Lee and Fran for helping to chair the session. And I hope you've all found it useful. I say I think the recording will be going up on the website at some point. And yeah, please come along to the future sessions as well.